So left image is the axial CT scan in a 55-year-old male who presented to the ER with an acute stroke, and it shows a hemorrhage in the right temporal lobe and external capsule with surrounding edema and mass effect. Right is the coronal CT angiography image in the same patient, and it shows a large middle cerebral artery aneurysm as the etiology for this patient's acute hemorrhage. CT angiography is often it's a key in evaluation of an acute hemorrhage in a patient with an atypical history or an unusual hemorrhage location. Left image is a non-enhanced CT scan in a 52-year-old hypertensive man with sudden onset of multiple cranial neuropathies, and it shows a pontine hemorrhage. Right is the axial non-enhanced CT scan in an elderly hypertensive man, and it shows a right cerebellar hemorrhage. The posterior fossa pons cerebellum is a relatively uncommon location for hypertensive hemorrhages, yet it is the third most common overall site after the basal ganglia and thalami. The left image is the non-enhanced CT scan in an 80-year-old man in the ER with a brain attack, shows a heterogeneous acute left occipital hematoma. Lobar hemorrhages account for just 5 to 10% of hypertensive bleeds. Right is because of the unusual appearance and location of the hematoma. Emergent CT angiography was performed in the same patient. Contrast extravasation into the hematoma, which is also called spot sign. It indicates the active bleeding. Surgery disclosed an actively bleeding hemorrhagic metastasis that was from adenocarcinoma. Left image is the axial CT scan, and it shows acute hemorrhage in the right cerebellum related to the remote cerebellar hemorrhage in a young patient who had a left temporal lobectomy. The etiology is thought to be related to the CSF hypovolemia resulting in the inferior displacement of the cerebellum and secondary venous injury. Right is the axial GRI MRI in this cerebellar hemorrhage, and shows the it shows the typical susceptibility artifact or the blooming related to the recent hemorrhage. The hemorrhage may be unilateral or bilateral or isolated to the vermis. Left image is the axial CT scan, and it shows the right cerebellar hemorrhage in this 86-year-old patient who underwent left-sided burr holes and catheter placement for the drainage of a left subdural hygroma. This hemorrhage was found incidentally. Most patients need no intervention for the cerebellar hemorrhage. Axial CT scan, right is the axial CT scan in a patient who is doing poorly immediately after surgery for meningioma resection, and it shows the linear cerebellar hemorrhages bilaterally along the folia, which is also known as the zebra sign, and this is a common pattern which is seen in cerebellar hemorrhages, and this external effacement is also present. So left image is the coronal gross pathology in section, and it shows a left germinal matrix hemorrhage with intraventricular extension and associated PHI in both the left frontal and temporal lobes. Note that the clotted blood extending outward from the left lateral ventricle into the medullary veins. Right image is a sagittal transfontanel ultrasound in a premature infant, and it shows a focus of increased echogenicity in the chordothalamic notch without intraventricular extension, consistent with a grade 1 germinal matrix hemorrhage. Left is the axial T2 weighted MRI, and it shows a small focus of hemorrhage in the left germinal matrix and along the right lateral ventricle in this premature infant with a history of oligohydramnios and a grade 2 germinal matrix hemorrhage. Right image is the axial SWI MRI in the same premature infant, and it shows hypointensity or blooming related to hemorrhage in the left germinal matrix and within the lateral ventricles. The germinal matrix hemorrhage typically occurs in premature infants who are less than 32 weeks gestational age. So the left image is the coronal ultrasound image in a premature infant, and it shows the increased echogenicity in the bilateral chordothalamic notch due to the germinal matrix hemorrhage, intraventricular extension of blood, and enlargement of the lateral ventricles, including the temporal horns. It's diagnostic of a grade 3 germinal matrix hemorrhage. Right is the axial T1 weighted MRI in a premature infant with a grade 3 hemorrhage, and it shows large bilateral germinal matrix hemorrhages and an extensive mixed intensity intraventricular clot with persistent right lateral ventricle enlargement. Left is the coronal T2 haste MRI in a fetus of 23 weeks gestational age, and it shows the decreased signal along the inferior-medial surface of the left cerebellar hemisphere, consistent with the cerebellar germinal matrix hemorrhage. Right is the coronal T2 haste MRI in a 33-week premature infant, and it shows the bilateral germinal matrix hemorrhages and associated ventriculomegaly. The right germinal matrix hemorrhage has extended into the right frontal lobe with surrounding edema in this patient with a grade 4 germinal matrix hemorrhage. The left image is the coronal transfontanelle ultrasound in a premature infant, and it shows a small increased echogenicity due to the germinal matrix hemorrhage in the right chordothalamic notch. The germinal matrix hemorrhage on the left is obscured by the intraventricular extension and very echogenic associated hemorrhage, PHI. Axial T2 weighted right image is the axial T2 weighted MRI in the same infant, and it shows the hypointense hemorrhage in the ventricle and the associated PHI. Note the radiating pattern of the medullary venous thrombosis in the PHI. So left is the coronal graphic, and it shows the atherosclerotic plaques involving the major intracranial arteries and their branches. Inset shows the penetrating lenticulostriate arteries and the lacunar infarcts. ASVD plaques are typically short segment, irregular, non-circumferential, and they may enhance. Right image is the axial T2 weighted MRI, and it shows a typical pontine perforating artery infarct. The basilar artery flow void appears normal. Left is the axial thin section 3 Tesla T1 MRI in the same patient, and it shows a crescent of hyperintensity in the wall of the basilar artery, suggesting intraplaque hemorrhage. Right is the thin section 3 Tesla T1 contrast enhanced MRI in the same patient, and it shows the enhancement of the subacute infarct. A partial rim of crescentic enhancement crescentic in the basilar artery wall is also present, consistent with the chronic inflammation within an ASVD plaque. So the left image is of a 68-year-old male in the ER with acute stroke symptoms at a negative non-enhanced CT scan, which is not shown here. Now the MRI shows extensive focal and confluent hyperintensities in the corona radiata and deep periventricular white matter of both hemispheres. Right is the axial DWI in the same patient, and it shows several foci of restricted diffusion that line up along the periventricular deep white matter of the left hemisphere. So the left is the MR perfusion in the same patient, and it shows no evidence for a major territorial infarct. However, there is prolonged mean transit time in the internal watershed zone of the left hemisphere, deep cerebral white matter. Because the MR perfusion scan suggested deep watershed zone ischemia, a DSA was performed. While there are some minor irregularities of both the proximal internal carotid arteries, no flow limiting stenosis were identified. The most severe disease affects the left cavernous ICA. Left image is the oblique view of the intracranial left ICA, and it shows irregularities in the cavernous or supraclinoid segments. High-grade stenosis of the M2 and A2 segments are present. Also noted is the irregularities of the more peripheral branches. Right image is the oblique view of the right intracranial internal carotid artery, and it shows a high-grade stenosis of the cavernous segment as well as multifocal areas of irregularity and narrowing of the more distal vessels. The findings in this case are those of severe intracranial ASVD. The left image is the axial CT angiography, and it shows a severe stenosis of the proximal left internal carotid artery with a small residual lumen. Also noted is that the typical peripheral mural calcification and the lower density lipid-rich core of the more central soft plaque in the left internal carotid artery. The right image is a graphic image, and it shows the mild form of ASVD, A with fatty streaks and slight intimal thickening. The severe form B is characterized by intraplaque hemorrhage, ulceration, and platelet thrombi. NSCIT calculation for the percentage of stenosis is actually, it is equal to B minus A divided by B multiplied by 100, where B is the normal ICA lumen and A is the minimal residual ICA lumen. So left image is the axial MP rage sequence, and it shows the intraplaque hemorrhage in the right ICA as a hyperintense crescent. Intraplaque hemorrhage is an independent stroke risk factor regardless of the ICA percentage stenosis. The right image is the coronal oblique MRA, and it shows the signal loss as a flow gap in the left internal carotid artery, indicating severely restricted flow, typically more than 95% stenosis. The patient underwent an emergency left carotid endarterectomy. So the left image is the axial MRA, and it shows a lack of flow in the right cavernous ICA. Also noted is the normal flow related enhancement of the left cavernous ICA. Axial right image is the axial T2 weighted MRI in the same patient, and it shows a vertical line of white matter hyperintensities. These lesions form a rosary-like pattern and are along the deep white matter watershed zone, where the cortical penetrating arteries meet the deep perforating arteries from the circle of Willis. They should alert the radiologist to the possibility of a flow-limiting lesion, often related to the carotid ASVD. Left is the axial CT angiography, and it shows a severe right common carotid artery stenosis with a very small residual lumen. Although DSA is considered the gold standard for evaluation of carotid stenosis, there is a linear relationship between the CT angiography and DSA measurements of the percentage stenosis by the NSCIT criteria. Right is the lateral DSA, and it shows severe short segment stenosis of the right ICA. This patient would be amenable to an endovascular carotid stent or carotid endarterectomy. Left image is the lateral angiography in a patient with left hemisphere TIAs, and it shows a high-grade stenosis. Distal to the left ICA bulb, multiple irregularities in the atherosclerotic plaque are seen here as outpouchings of contrast. Irregularity is an independent risk factor for thromboembolic stroke, making this an at-risk plaque. Right image is the lateral angiography in the same patient, and it shows the long segment stenosis of the right internal carotid artery origin. Also note the subtraction artifact from dense wall calcification.